Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Max. How are you doing this morning?
Good. Thank you for having me on, Dennis. I really appreciate it. It's always a pleasure and honor to be here.
Hey, well, the pleasure is all mine. So today I'm going to lean on your experience as well, and we're going to talk specifically about hemorrhagic shock and the progression of shock and when to actually start resuscitation if needed, right? So if you wouldn't mind just starting in, you've seen a lot of casualties. Would you mind just starting to walk me through shock from, we find this guy and he's covered in blood. There's blood on the ground. Like, how does this shock go if nobody does anything?
Yeah, perfect. So, the traditional classes of hemorrhagic shock, we have class 1, 2, 3, and 4. And it is a progression based on how much blood you've lost, and then the physical exam findings that are associated with each class based on how much blood you've lost. They are good. There are some nuances to it, and some people think that, oh, well, this is what is explained to me and written down in textbooks, so every human being must follow the textbook. And that is not the case. These classes of shock are really how a normal, physiologic, perfect human being specimen would act when being evaluated in a vacuum by all the correct monitoring and people with clear head and clear mind, and follow the normal appropriate physiology again in a vacuum. They are good for an academic standpoint, and they are used again for creating a lot of like our algorithms and studies even. But like most people know, the human body and the scenarios that we're in very rarely follow the textbook. And so there's a couple ideas that I want to go through that I want to hit on when we're going through the different classes of shock. And so realistically, when we're approaching this class 1 through 4, hemorrhagic shock specifically, I want you, the listener and viewer, to understand that the real important divide in the classes of shock is not the classes themselves, but this term of compensated versus uncompensated shock, because ultimately that's what it all boils down to. Is your body and all of the stuff that you've been given from a physiologic standpoint from years and years and years of evolution, are all those tools compensating for the blood loss and maintaining perfusion to the end organs, or are those compensatory mechanisms not working, right? And so that's when I say compensated and uncompensated. Compensated is that you have all these things in place: the sympathetic tone, blood volume reserves, all this stuff that allows your body to deal with lost blood and then mobilize the blood that is in your body either faster or more effectively to the organs that need it and maintain end organ perfusion. So compensated is, I've lost blood, but my faculties allow me to maintain end organ perfusion. Uncompensated shock is, I've lost blood, and now I've also lost the ability to maintain end organ perfusion. And that is the point. That is the place that you do not want to be. You do not want to be in uncompensated shock, because once your organs start to lose the ability to perfuse and get oxygen from the environment to the tissue, there are things that happen that are very, very hard to reverse. It's not just like turning the switch on and off, right? So class 1 shock, you lose under 750 cc's. That's donating a unit of blood or less, right? And you donate a unit of blood, you're fine. Your body compensates, and if you need it back, you get it right back. We do that all the time in training. That is the switch on and off. If you're compensated, you can turn the switch on and off. You lose some, you get it right back. Nothing's changed, right? When you get to uncompensated shock, you can't just give it right back. You got to give it right back, and you got to do other stuff. You got to give more than what was lost. You got to give other stuff like electrolytes, calcium, other medications to get the patient back to where they were, because all of the damage that's been done by that hypoxia, by that loss of tissue perfusion, has had a much more profound effect. You've now got cell death. You've got cytokines floating around. You've got protein floating around, clogging the kidneys. You've got calcium and potassium leaking out into the heart and causing cardiac abnormalities. You could potentially have reperfusion injury and reperfusion syndrome when you start giving blood back to these patients, right? So there's all these metabolic derangements. They call it historically, when you read old textbooks, that the wheels are starting to come off the cart, right? And so just because you had a wonky wheel for a while, you fix that wheel, but your axle's been screwed, all the joists have been screwed. You've got to fix more than just that wheel if you run it ragged long enough. Does that make sense? Yeah. Yeah. And so let's start. There's 4 classes of shock, like I said, but the key thing to remember is that in your mind, when you're learning this and you're practicing this as a medic or whoever, young resident, draw a dotted line right down the middle, class 2 and class 3. And class 1 and 2 are compensated, class 2 and 3, class 3 and 4 are uncompensated. And keep that in your mind, because you don't want to be on the wrong side of that dotted line. So class 1 is about 750 cc's of blood loss or less. And it's, like I said before, the equivalent of like donating a unit of blood. And then real quick, class 2 is 750 to 1500. Class 3 is 1500 or 1.5 liters to 2 liters. And class 4 is anything greater than 2 liters. And right off the bat, if the average adult male has 5 to 6 liters blood in them, that's not a lot, right? So when we're talking about percentages, it's 15% for class 1, class 2 is 15 to 30%, class 3 is 30 to 40%, and class 4 is 40% or more. So 2 liters doesn't sound like a lot. Like, you get a 2-liter bottle, 1 liter, 2 liters, and you put that, you're like, man, looking at one of these big operator types, you're like, I didn't expect that much blood to have this much of an effect, right? And that's one of the things I stress. On a real quick aside here is, like, when you are a young medical provider taking care of trauma patients, 2 liters of blood loss is a visually impressive thing. It doesn't sound like a lot because we're all used to seeing like 2-liter bottles of Coca-Cola, but like, I encourage someone to like fill a 2-liter bottle of water, dye it red, and spill it on the floor, the whole thing. It is a impressive and unbelievable sight, especially blood. Blood, really, it's not like a water-based liquid. And even 10 cc's on the floor can look impressive. 2 liters will cover an entire room. That's one of the things like that I hit on my hospital people in the trauma bay all the time, on my residents and my medics in the trauma bay and nurses. When the EMS brings the patient in and they want to just start doing the primary survey right away, I'm like, everyone stop. Listen to what EMS has to tell you, because from a trauma perspective, they're going to tell you the most important thing, which is how much blood was on scene, right? And you will know, like, asking the EMS person or the medic from POI how much blood was on scene, because you'll look them in the eyes and you'll say, hey, how much blood was on scene? And they will tell you. They will tell you with their eyes, because 2 liters or more of blood loss at scene is a lot, especially for someone who's never seen it before. they'll tell you, and you know right away, okay, we're in the danger zone already, right? And so that's something that's very important to understand, is that communication. And because in trauma, that's one of the most common places to lose that blood volume is on the floor. We talk about the abdomen and the chest and the retroperitoneum all the time and the thighs, but like 2 liters of blood loss on the floor is something that having the comfort of being in a trauma bay, I rarely see out in the environment what's at POI, right? So those medics, that's probably the single most important thing that you can garner from the people bringing that patient in your door is how much, like, look them in the eyes, ask that question, how much blood was on scene? You will get your answer before they even say a word. And that is something that has stuck with me for a long time, and it is an incredibly important question, probably the most important question to anyone coming in the door who's giving you a mist or a field report. So class 1, 750 cc's, 15% blood loss, right? Another way I remember it for people trying to remember this at home is it's a tennis score, right? 15, 30, 40, love, right? So that was something that was stupid and told to me as a resident, but it works, right? So those are your classes of shock. 15, 30, 40, love. Done, right? So 15% of or less of blood loss. What are you going to see, right? You might see a change in your heart rate, probably not, because we don't get tachycardic when we donate a unit of blood, right? Our blood pressure is going to be normal. Our pulse pressure, which we're going to talk about here in a second, is going to be normal. They're not going to be orthostatic. Their capillary refill is going to be normal. The respiratory rate's going to be normal, 14 to 20. Their urine output will be normal, and their mental status will be normal. So it's all normal. Okay, well, why is it normal, right? It's because they've lost a little bit of blood, but their body is able to compensate. It took the hit, but guess what? We have a certain amount of blood on reserve. Depending on who you are, healthy, young, adult, military age male, and even pregnant patients have a lot of blood volume that's sitting around in their veins, right? Our venous system, our IVC, is a capacitor. And so there's about at any point in time, 20 to sometimes 30% of our blood volume is just sitting around, not static, but moving a lot slower than on the arterial side, sitting in our venous system, ready to be used at a moment's notice, to get pushed out and fill in any gaps, whether you're stressed out, right? If you're digesting something and you need to dilate some blood flow to your intestines, or if you're exercising and you need to dilate blood flow to your muscles, right? That blood is sitting there in your venous system, in your IVC, and all your big veins and all your small veins, sitting there ready to be utilized. It's your reserve, right? Your capacitor system, right? And so when you lose that 750 or less of blood, what happens is your body mobilizes the reserves, right? And we like to think that veins don't have a muscular component, but they do have some ability to spasm. And we've all seen it on ultrasound, or when we're trying to get peripheral IVs, you stick the vein and you miss it, you mess it up, and all of a sudden it's like, oh, it's spasmed down. And it's like, well, hold on. I thought you told me in med school that arteries have muscles and veins don't. That's not entirely true. Right. The veins definitely have a capability to spasm, and that's what they do. Right. And so when you lose about 750 cc's or less of blood, those big veins and all the veins in your body clamp down a little bit. And we're not talking about arterial clamping. We're talking about all the your deep vein reserves, squeeze a little bit and mobilize that extra 20% of your blood volume that's sitting around, quote, not doing much. Right. And so that is the first line of your ability to compensate, is mobilizing the venous reserve. And if you'll notice, there's no vital sign that checks that, right? There's no vital sign that's like, oh, well, I can see his IVC clamping down. It's like, no, it doesn't work that way. Like, there's no increase in heart rate. There's no increase in cardiac output. Like, that's the point. You are just mobilizing a reserve volume that you have historically and, evolutionarily been given to survive, right?
Yeah. So would that be like if you could, I don't know, section off the sympathetic response? Maybe that would be like your first gear in your sympathetic response.
Yeah.
And then, I mean, especially if something traumatic happens, like I know physiologically they have a normal heart rate, but like, I don't know, psychologically, like they've been injured. That at least I've seen their heart rate is high, but not abnormally high, like 110, something like that, 110, 120, but they're upset.
Yeah.
They still have their faculties, but they're upset.
Exactly. Yeah. And so that's a great way to look at it. Like, this is first gear of your sympathetic response or your ability to compensate. This is the first line. Exactly. And another thing you brought up too is like tachycardia. 100 is not tachycardia for everyone, right? Like, sometimes a lot of our guys, they're professional athletes. A lot of their like resting heart rates. My resting heart rate's in the 50s. When I broke my femur and had to get 2 units of blood loss, they didn't want to give me that blood despite my hemoglobin being down to 5. And me being like orthostatic, because my heart rate was in the 80s. But if you look at that, like, someone who's got a baseline heart rate in the 50s who goes up to the 80s, that's tachycardia, right? So like that's something that we got to think about with our guys that are super healthy. Like these operator types, these resting heart rates are sometimes in the 40s, right? You go to 80, they've doubled their resting heart rate. That is tachycardia, right? And so we draw a line in the sand at 100 because it's easy to remember. But because for most people, 100 is tachycardia, right? For the overwhelming majority of the population. But if you're someone who really understands physiology and understands your patient population, they could be hitting tachycardia before 100, right? And that's something that you got to get clued into. And so, yes, so that's just another pearl, or something to think about when you're dealing with the patient population that is a professional athlete, basically, right? And so, yeah, so the first thing that gear 1 is mobilizing the blood reserve. There's no vital signs changes to that. There's no way to externally assess that is being done or to what extent that's being done, right? It just happens. It happens on the inside, and all the stuff we use to measure pulse rate, blood pressure, pulse pressure, orthostasis, cap refill, respiratory rate, urine output, it's all fine because we've mobilized an extra reserve of blood volume. We lost some, and now we got some from our reserves. That's class 1 shock, right? And again, it's hard to tell, like, are they tachycardic because they're stressed out because they just spent the last hour in a gunfight, right? And they're smoked. Or are they stressed out because they took a bullet to the thigh and that hurt a lot, right? Like both of those things can be very, very adequate reasons to have be tachycardic because you're stressed out, not because you've lost that much blood. So again, we're already muddying the water. We're just in class 1 shock, and it's like, oh man, like they could be tachycardic and they've mobilized a whole bunch of blood, but like everything looks normal or it doesn't look normal. They're still tachycardic, and don't get stressed out, right? When you're trying to understand this, it's like, just understand that yes, this patient has come to you, they're on a litter, but at the same time, they were just in a gunfight. They've suffered some sort of injury. Those are both very real reasons to have real tachycardia. So we've got to look at some other things, right? However, I will tell you that, and I tell this to my medics and residents and everyone I teach, is like, you do not get to tell me that tachycardia in a trauma patient is due to stress, pain, anxiety, whatever, until you have proven that it is not due to hemorrhage. Because the golden rule in trauma is that all hemorrhagic shock patients, all patients that are trauma patients that have tachycardia, it is hemorrhagic shock until proven otherwise. Could very well be something else, right? But a trauma patient who's tachycardic is bleeding until proven otherwise. It is your responsibility as the medical provider to prove to me and yourself and the patient and God that that is not from bleeding, right? And so it muddies the water, but do not let this podcast or what I said a minute ago say, like, oh, well, Dr. Sirkin said that they're tachycardic because they got shot. Wrong. They're tachycardic because they're losing blood. You have to prove to me that it's not that's not what's happening, right? And then you can say, oh, well, oh yeah, duh, they were just in a gunfight. I've done everything. They're not bleeding anywhere. I did all my stuff, right? And I can show and be confident that they haven't lost blood or are not continuing to bleed, right?
Right.
And,
Now,
yeah.
likewise, you're also not saying send 2 units of blood.
Yes, I'm not saying that. I'm saying you need to do what you are trained to do and evaluate the patient, right? And see where exactly they are on the spectrum and then treat appropriately, right?
Yes.
So, we'll talk about that. Let's talk about how we evaluate someone in one of these classes of shock. One of the things I mentioned, I went right down the list on talking about compensated versus uncompensated. And these are things that we got to be looking at, right? So, pulse rate, self-explanatory. There's a bunch of different ways to check a pulse. You can check carotid, femorals, radials, DPs. There's a rule of thumb that I use that is good in healthy young people, but not good in elderly people that have bad vasculature or peds that it's very, very hard to feel the pulse on these little kids, right? But in a young, healthy military-age male, the rule of thumb is that if you feel a carotid pulse and no other pulse, then their blood pressure is at least 60, right? So if I feel a pulse here and it's weak and thready, but I don't feel it in the radials or the femorals, this is 60. So 60, and this is the only one I feel, it's about 60, right? If I feel carotid and femoral, but no radial or DP, it's about 70. And if I feel carotid, femoral, and if I feel a radial pulse, the radial pulse is at least 80, right? And if I feel a DP pulse, it's usually around, you can safely say it's at least, it's definitely probably 80, definitely probably, it's 80 to 90, right? And so again, those are rules of thumb, but like when I'm unable to feel a radial because it's so weak and thready, but I can feel a femoral or I can feel a carotid, I know it's somewhere around 60 to 70, and we are at least in class 3 shock, if not blown way past it, and are in 4, approaching 4 very quickly. Does that make sense?
It does.
Yeah.
It does. I guess I really don't like tying it to an exact number because those people will document that as, well, it's 80 over PELP, which
Yeah.
is not at all what that means.
And yes, and do not, and that's why I say these, I like to refer to those numbers because it tells me really what the body's doing. And the body is clamping down and doing what the body does to survive. So to me, I look at that numerically. And there are some studies that do show that there is correlation between those numbers and where you can feel it. But don't get stuck on the number. Get stuck on what the body is doing, right? If I feel a radial pulse and I'm able to palpate a radial pulse, I know that their compensatory mechanisms are such that blood is getting to their fingertips, right? That's good. If blood's getting to their fingertips, it's also getting to their lungs, brain, and kidney and gut, right? So that, to me, if I feel a radial pulse or a DP pulse, I have a sigh of relief. a little bit of a sigh of relief. I'm still concerned because they're probably still approaching or in class 3 shock, based on other things I'm going to be looking at. But if you feel a radial pulse, don't, slap high five. Just know that you're at the point where, like, as of right now, they are getting blood to their fingertips. If you feel a femoral pulse, but no radial pulse, okay, now you need to understand that you're in class 3 shock. 100%, right? Because now their body is clamping down to the point where their fingertips are not getting adequate blood, right? Their cap refill is terrible, right? And if their fingertips or their toes are not getting adequate blood, it's safe to assume that there might be stuff on the inside that is not getting blood, like the kidneys and gut, right? And then if you can't feel femoral pulses, but you feel a weak carotid pulse, their body is doing everything in its power to do what it does right before you die, which is maintain blood flow to the brain, because this is the last place that your body sends blood. And when you lose consciousness, you're seconds away from a heart attack, right? Because if blood ain't going here, then all of a sudden it won't have enough to go here either, right? And your coronaries lose blood flow right after your brain does, right? And so this is what I would call the ability with your finger to assess how bad your body is doing damage control, right? And so if you can't feel femoral pulses, but you can feel weak threaded carotid, your body's on damage control pretty freaking bad, right? And so that's the pulse rate. That's how we assess. Moving on to blood pressure is, again, numerically kind of what we were talking about just now, right? Where we are on this spectrum. And for class 1 and 2 shock, it is normal, right? Your blood pressure is normal. That's kind of the definition of compensated, right? Your body is compensating through all these mechanisms that we're going to talk about here in a sec, to maintain that pressure head to the rest of the body, right? It does certain things. Your body does things. I guess we can jump into it right now, right? So again, if you think of compensation, your body's ability to compensate, what does that mean? It's really your body's ability to maintain oxygenation of your peripheral tissue. And it does that by maintaining an adequate pressure head of blood to the distal tissue. And so by definition, if you are in compensated shock, your blood pressure is normal, right? And how does your body do this? With the sympathetic system, right? Your sympathetic nervous system. So the first thing we talked about is a little bit of venoconstriction and mobilizing the reserve of blood in your venous system. That's step 1. Step 2 is going to be increasing it's going to be 2 things. It's going to be increasing your heart rate and then increasing your pulse pressure. Again, all these mechanisms are starting out peripherally and then they go central. So step 1 is just mobilizing your reserve. And then step 2 is going to be some central action of just increasing your heart rate, but also another type of constriction that we're going to call the pulse pressure narrowing, right? And this is something that a lot of people don't understand, but let's talk about the heart rate first. So your heart rate gets jacked up because you have less blood, right? You have less blood, you've employed your reserves, but it's still not enough. So then your heart is like, okay, well, I have less blood, so the smaller amount of blood I have, I'm just going to mobilize it faster. I'm going to beat it faster, right? So if I can't make up for the volume with each push, I'm just going to beat it faster throughout the body, right? To maintain that pressure head. Okay, less volume, so I'm going to push it faster to maintain that pressure head, right? That's step 1. Step 1.5 is the peripheral arteries are going to squeeze a little bit. And so Pulse pressure is the difference between your systolic and your diastolic blood pressure. So when your heart squeezes, that initial pressure head is your systolic blood pressure. That's the peak, the high number that you get. I'm squeezing, the blood rushes out, and it's that initial slam against the arteries distal that the blood pressure cuff detects, right? That is your systolic blood pressure. That doesn't change. What does change is your diastolic, which is once you squeeze that blood and the pressure head goes out and then slows down, there's a baseline level of flow and there's pressure to that flow. It's not like your blood in your arteries isn't going like this. It's not a ratchet. It's not going boom, 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 boom. It's going like this, right? And so, there's a pressure wave, but even when the pressure wave dies down, it's still flowing forward, right? And that forward flow, when the heart relaxes, has a pressure to it, right? That is your diastolic pressure. Well, what happens when your peripheral arteries start to clamp down based on sympathetic tone, right? Now we're talking about the arteries that do have very strong muscles in them. They will start to clamp down. And what happens when they clamp down is that pressure, when it's flowing forward and the heart is now relaxing, right? You get that initial systolic, and instead of coming back down to here, you get the initial systolic, and then you go to here, because what's happening is the arteries are squeezing, they're becoming tighter, and that diastolic blood pressure, that baseline pressure of flow, rises, right? And so you see a narrowing or a drop in your pulse pressure. And this is a lot of people that don't understand this concept are just like, oh, a drop in pulse pressure is a drop in blood pressure. Wrong. There are two fundamentally different concepts. Your pulse pressure is the diastolic rising, and that gap between systolic and diastolic blood pressure narrows. That pressure gets smaller, right? If my systolic blood pressure at baseline is 120/80, then my pulse pressure is 40, right? When I lose blood and my peripheral arteries start to constrict, my systolic blood pressure stays at 120, but my relaxation pressure, the relaxing pressure, comes up to 120/90, 120/100, and now my pulse pressure went from 40 to 30 to 20, right? And that's my peripheral vasculature squeezing. So your pulse pressure, which you can measure with a manual or electronic blood pressure cuff in seconds, is you visualizing how hard your peripheral arteries are constricting. And that's important. That is a vital sign that we don't really talk about, and it's so valuable. Because now, granted, you do have to trend it, so there's a little work. There's a little work to know what your guy's baseline was, right? But at the same time, your diastolic pressure shouldn't be like 90 to 100, right? Like if you got a guy who comes in and they're covered in blood, they're with it, they're talking, they're anxious, they're scared, right? And their heart rate's in the 120s, 130s, 140s, right? What I talked about before is, okay, trauma patient, tachycardic, right? Who's missing a leg, is very real that that guy has a lot of pain and stress and has a lot of valid reasons to be tachycardic. But I've told you, trauma patient, tachycardic, you need to prove to me that it's not from hemorrhage, right? And when I see in that guy a diastolic blood pressure of 90 or 100, I am worried that there is blood loss. Obviously, they've also lost a limb, so I know there's blood loss, right? A significant amount of blood loss. But that is one of the things that if you see, it is leading you down the road of like, there's been significant blood loss, right? And so that diastolic number that we poo-poo all the time, medics are so stressed out, their OODA loop's going crazy, right? And they just want to be like, oh, well, I got a number over palp. That's fine. Like, move on, right? They're 120 over palp, or, like they don't even bother to get the diastolic number. That diastolic number is a lot of valuable information. It's valuable information to know where they are on the spectrum and where they're about to be, right? How hard. It's a valuable data point to tell you how hard your patient is working the compensatory mechanisms, right? And so I get really worried when I see a young dude who's in a bad trauma and their diastolic pressure is approaching or over 100. That tells me that they're squeezing down really, really freaking hard and the wheels are about to come off, right? And so that is something that's concerning to me and something that isn't taught well. I'm embarrassed to say that I did not learn that concept until much later than I should have learned that. So it's an important concept. Now class 1, orthostasis. Let's stick with compensation, right? So the third thing that your body does, if you want to talk about the third gear of compensation, or we could talk about, I really like your analogy. First gear is mobilizing your venous reserves. Second gear is going to be tachycardic. Third gear we'll call the squeezing of your diastolics, squeezing of your peripheral vasculature, and the rise of your diastolic or the drop in your pulse pressure. And then the fourth thing is going to be increased cardiac output or contractility, right? And so this is something that, again, you're not going to really be able to assess unless you're really good at POCUS or point of care ultrasound, which honestly, if you're a medic and you have an ultrasound, like this is probably something you should learn how to do is putting an ultrasound on a probe on the heart, not just to look at like pericardial fluid, which is easy, but to also look at like how hard that heart is squeezing, right? Because it does take practice. There are some nuances to it, but it's a valuable point, right? Like if you can throw a probe on a dude like we just described, and you see that their heart is squeezing so much that their ventricular walls are just like clapping together, right? And then you're like, man, this dude is squeezing freaking hard. It's a little bit muddy because like our guys are so healthy that that they've got just great contractility to begin with. But like again, it's another data point, right? It's another data point to show that this guy's tachycardic, their pulse pressure is super narrow, their diastolic's over 100, and you throw a probe on their heart and their ventricular walls are just clapping so hard that you can hear it through their chest. Like that's a guy who is enacting all four of his sympathetic cards, and he has nowhere else to go, right? The only place he has to go is to fall off the ability to decompensate, right? And so then the next thing is orthostasis, right? This is kind of hard to assess in a trauma situation, but not impossible. Honestly, it's more just like looking for red flags. I don't know if I would actually test this as someone who's been orthostatic from trauma. It's really not fun. And the last thing you want to do is like be dealing with a guy that feels like they're going to have a heart attack or vomiting, right? Is kind of like one of the things that can happen. But if you've got a trauma guy and for whatever reason you sit him up and he gets really lightheaded or dizzy or feels like he's going to puke, that is a damning sign, right? Like now that tells you that they're compensating so much that when you change the position of their body, that they can't even compensate against the effects of gravity, right? And so their sympathetics are so taxed out that when you shift literally the configuration of the volume in their body, they temporarily or permanently can't deal with that. And the last thing you want to do is intentionally sit someone up to see where they're at, and then they pass out. And now you're laying them back down, and you're lifting their legs and doing the opposite and giving them blood, right? So like, that's not really something that I would like test. But it's definitely something to notice, right? Like if the dude doesn't want to sit up because they tell you, man, if I'm gonna sit up, I think I'm gonna pass the fuck out. That should be a huge red flag to you. Now, could it be a TBI or something? It could be, but again, you have to prove to me that all this stuff is not from hemorrhagic shock, right? And so, there's plenty of dudes who get their bells rung from explosions or helicopter crashes, right? And they've got bad TBIs and their vestibular system's all messed up. But again, you do not have the fortune or ability to tell me that that is from a TBI when it's a hemorrhage, when it's a potentially hemorrhaging trauma patient, right? And so, next is
Two
sorry.
other, I guess, two other things I've seen is like these guys will be taking like these big heroic breaths, like their breathing has gone into overdrive, like they did in wind sprints.
Yes. Yeah. And so that's the ability, that's the you start to see that in class 2. So I guess, yeah, that would be, we can call that 5th gear, right? And so that is your body trying to get more oxygen in your blood, right? And so you're breathing faster. You're breathing deeper. You're right. It's hard to say whether or not, like, if someone's breathing real rapid, that's kind of rare, right until like until right before they crash, when they're doing like the really rapid guppy breathing. That's usually
Yeah. That wasn't what I was talking about. I was talking about like this deep breathing,
correct.
like they just got done with the run.
Correct. Yeah. No, exactly. And so, yeah, so you'll see these guys exactly. They'll take a bunch of fast breaths, but then they'll pause and they'll take a big deep breath, right? That is someone who, again, they could be smoked because they just came off the X, or they've just been injured, right? And now they're getting their parasympathetic dump, right? But it could also be someone who is just starving for oxygen because their body's trying to get more. And again, like I said, there's a theme here. You don't get to tell me that it's because they're tired or because they're exhausted because they just did this physically heroic thing. The theme here is that all the stuff we're going through is all stuff that happens when we exercise hard, when we enact our sympathetic nervous system, which, guess what? War is a great time to enact your sympathetic nervous system. But you don't get to tell me that any of the stuff we're seeing is from sympathetic tone, from combat or stress, physical stress, until you've proven to me that it's not from hemorrhage and compensating for blood loss, right? And so, breathing rapid, you'll have guys like, they'll try to sit there and watch the chest rise and fall. They'll put a pulse ox on, right? It's uh it's not so much the hard numbers, the rapidity. It's like you described, the quality of their breathing, right? You can tell, obviously, when someone is breathing really hard. And that should be a clue that they've enacted one of the gears of sympathetic compensation, right? When you're looking at someone and they are very obviously breathing 40, 50 times a minute, you're too late. Like now, like you can't breathe 50 times a minute, 40 times a minute and be mentally with it, right? So that's what I was trying to say, the guppy breathing, the rapid shallow breathing. That's usually someone who is passed out or is about to pass out. Like, breathe 40 times a minute. You can't do that for more than a minute. Like, you're doing that, you've got seconds to minutes before that person passes out. It is a very late and concerning finding. And then we're talking about now urine output. Urine output is a great measure of how much blood someone has lost and how much the end organs are perfusing. I call it like the ultimate, like, to me, it's kind of, and it's not the gold standard, but to me, it's the gold field standard, I'll say, of end organ perfusion, right? Because what you're doing is you're measuring the kidney's ability to get blood, right? The kidney is a major internal organ, and it is one of the things that the body fights inside your body to protect. And so it's a bellwether. It's a great bellwether because I can put a little piece of plastic in the bladder and measure how much urine is coming out. And that tells me how much blood the kidney is getting. And if I know that the kidney is getting enough blood, well, as a bellwether, I know other things of less importance are also getting blood, right? The kidney goes before the heart, lungs, and brain. So if the kidney is not getting enough blood and I'm not making enough urine, then I know, okay, there's probably also some injury, definitely to the gut, definitely to the muscles, and probably the heart, lungs, and brain, right? The problem with urine output is that it's not a raw number. It's a trend, right? And I got to wait at least 1 hour to figure out where I am on that spectrum, which we don't have, right? And so it's great, but I would say that it's great for trending your initial interventions and also in a prolonged field care aspect, right? But a trauma patient coming in the door in the trauma bay, the urine output really doesn't have much value because of the constraints of the situation. I would say it has immense value after initial impact, and the Foley should go in and should be used as a trend of your care and a trend of the patient's physiologic responses. But initially, on that initial in the door assessment, it is just not valuable because it takes time to get an accurate measurement of that, right? And then mental status. Man, you could write a whole book on this. This is something that is hard to describe unless you've seen it and you've seen all of the different variations of it. But a dude who's been shot or had a traumatic amputation should not be sleepy, right? Now, again, um, you know, there are reasons for a dude who's had a traumatic amputation to be sleepy, right? Maybe he got thrown 10 feet after his leg was ripped off by a rocket, right? And he's got a bad TBI. That's a valid reason for that dude to be confused and sleepy, right? Maybe the medic, the partner force medic gave that dude a fucking massive slug of drugs, right? Also another reason for that dude to be confused and sleepy. But again, the common theme here, you do not get to tell me that a guy's altered mental status in a trauma patient is due to drugs or TBI. It very well could be, and those are probably more common reasons. However, you do not have the fortune to tell me that the altered mental status in a trauma patient is due to a TBI or drugs until you have proven hemorrhage is not the cause, right? Because lack of blood flow to the brain is presented by confusion and sleepiness, and then they're unconscious and dead, right? And so these guys will come in drunk, they'll come in confused, and they'll basically, I describe it as drunk. I can't tell you how many people come in the trauma bay in my civilian trauma center that I just on initial assessment, I'm like, that guy is kind of drunk. And then the doc screen comes back and they're not drunk, right? And there's no alcohol on board. It's like, oh, like you shouldn't be waiting for that to tell you that like that's the wrong way to do things. However, in retrospect, I've always kind of like had a running game with myself. Like, I wonder if this is blood loss with alcohol on board or just blood loss. And sometimes it's just blood loss, and I've been pretty surprised that that's a little bet that I have inside. I still treat it like blood loss, but I'm always kind of wagering in my mind, like, I wonder what else was going on. And a lot of times it's just blood loss, which is pretty impressive. And so that is definitely something to be concerned about. These are, again, all of the red flags that should cue you in on where this patient is on the chart, right? So just to review, class 1 and class 2 are compensated. Your body is enacting all the mechanisms of compensation we just talked about. And the blood pressure is maintained. Oxygen from the air into your lungs, into your blood, into your heart is getting to the tissue adequately in order to maintain perfusion to your tissue. That is class 1 and class 2 shock. And it does it with all those different gears we just talked about, right? Class 3 and 4, you have lost the ability to do that, right? And class 1 is 15% of your blood loss, 750 cc's. Class 2, 750 to 150, or 1500, or 15 to 30%. And then when the wheels fall off, you're approaching 30 to 40% class 3, or 1.5 liters to 2 liters, or more than 2 liters, more than 40% for class 4. So we've talked about class 1. We've talked about all of the vital signs and different parameters that we're going to check. And guess what? They're all normal, right? Because all we've done in class 1 shock is mobilized our venous reserve. We've gone into first gear. We mobilized our venous reserve. Everything else is normal. Class 2. This is important because hopefully most of your patients don't go past class 2, right? But there's a lot of patients, like our military age males, that will stay in class 2 for a very long time, because class 2 is where we are enacting all of the other gears of our sympathetic response. We're in second, third, fourth, and fifth gear, right, in class 2. And it's only once we're in fifth gear and the wheels come off are we in class 3. But you'll see that a lot of our healthy military age males have an amazing ability to compensate, meaning that they will stay in class 2 shock based on your physical exam until they have lost so much blood that they don't present class 3. And that's a weird thing to, like, I know if you're new to this, you're like, how does that happen? Like, everything should go in order. And I'll tell you why, because let's go down class 2. So now you've lost anywhere from 750 to 1.5 liters of blood. Your heart rate has now started to go up, right? You are now tachycardic, whatever that definition of tachycardia is, but we use greater than 100 because that's tachycardic for most males, most adults, right, is over 100. Now, you should be keen on what your guys' baseline heart rates are, especially if it's a team that you work with every day, because tachycardia could be a lot earlier than 100, but they're tachycardic. Class 2 shock is the first time you see them enacting second gear, and their heart rate has now gone up because they've lost blood, and they now are pushing the lower amount of blood they have in their body faster, right? Their blood pressure is normal because this is compensated shock. All the mechanisms we're going to talk about are compensating, and their pressure head and their distal tissue perfusion is normal. The pulse pressure is now starting to narrow. So we're in second gear, right? We're in third gear. Second is the heart rate. Third is the squeezing. Again, this is just something that Dennis and I just came up with, but like, it's not like you have to have second before. No, it's just we're enacting another compensatory mechanism, which is we're squeezing the peripheral vasculature. And your diastolic blood pressure will start to rise, and your pulse pressure will start to drop, right? Orthostasis, not really present. Can be, but not really present in this class. A lot of charts will say minimal. I'm going to say it's not there because to me, your orthostasis is kind of the first sign that you've lost the ability to compensate. You're compensating when you're laying flat, but when I sit you up, you lose the ability to compensate. That tells me that you're really not compensating, right? You've lost an ability to compensate based on where gravity is affecting you, right? So if you're having orthostatic changes, I would say you're in class 3 or about to be in full-blown class 3, right? And in our patient population, what that means is you're about to jump right from class 2 to class 4, right? So I would say orthostatic changes are not really something you should see in class 2, but they are a late finding. And probably I would say if you have orthostatic changes, you're not in class 2. You might think you are, but you're past it, right? Because your body can't even compensate against gravity at that point. Cap refill, you will start to have a sluggish change in cap refill, meaning that you do have a good cap refill, your hands are still warm, but there's some changes that are happening. Your peripheral vasculature is squeezing, and your blood flow is a little less, that it's not normal. I would not say, they always say, oh, it's delayed. I wouldn't say it's delayed, but like when you squeeze on someone's fingers and there's a normal cap refill, it's pretty obvious. Delayed is also pretty obvious. It's not normal. Your cap refill is sluggish, I would say. Not significantly delayed, like they don't have white cold hands, but like it's definitely not normal. Your respiratory rate has started to increase, right? So another what I would say gear of compensation is they've started to increase their respiratory rate. They say the book says 20 to 30. I would say they're breathing like someone who just ran a marathon, right? They're breathing hard. Like you just described, Dennis. They're taking those, they're breathing fast, but they're also taking those big deep breaths like they just got smoked in PT, right? And urine output is not something that we're going to measure, but it does start to go down to possibly 20, 30 cc's. But again, it's enough to maintain perfusion to the kidneys, but you're not seeing the, 40, 50, 60, 70 cc's of urine output that you would see in a normal, hydrated, healthy operator, right? And then mental status. They're going to have some anxiety. They're going to be stressed out, right? At this point in time, they've suffered an injury enough to where they've lost a decent amount of blood. They're going to be stressed out. Again, and they're going to potentially be, I wouldn't say they're not drunk at this point, but they're going to be stressed out, right? If you have a patient that's like acting drunk, I'm very concerned, again, that they're already in class 3, 4 shock, right? Because if their brain is not getting enough blood to act normally, we're past the body's ability to compensate, right? And so you really shouldn't see significant mental status changes at this point in time. But anytime you do see a mental status change, you really need to be thinking, okay, did they just get a drug? Like, or, did he have a bad TBI, right? Like, no, you need to be thinking like, oh, okay. Like when I see a guy and they come in and they're talking and they're walking in there and they're joking, or like, saying like, a dude comes in with a gunshot wound and they try to brush it off with some, I don't know, fucking saying like they're John Wick or Arnold Schwarzenegger. They'll usually have some quip, right? Like some of these guys will have some quip of like, oh, the injury's not that bad, or oh yeah, whatever. And like that tells me they're good, right? They're good up here, right? If that same guy you circle back around and they're like not like that, I'm always like, hey, did you just give this guy some ketamine or Dilaudid? Like what? And 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 I'm like, ooh, like I don't like this. Like you weren't the same, like gallows humor guy you were 10 minutes ago. That should be a red flag. That should be a big red flag. Like attitude changes, especially someone who right? And you live with and you're on the team with, right? If they start having like attitude changes and not acting like themselves, that is a big red flag, especially if you've got all the other stuff that they're approaching decompensation, right? And so that's class 2 shock. Now you may ask, okay, well, how does someone blast through class 3 shock, right? Because let's talk about class 3 shock. Let's talk about the first level of decompensation, right? So now you've lost 1.5 liters to 2 liters of blood, 30 to 40% of your blood volume. Your heart rate is going to be very high. at least in the 120s, maybe even higher. Your pulse pressure is going to be very narrow. So these are the guys that have like maybe a pulse pressure of like 20, right? Like, and it's made even worse because this is also the time when you see their systolic blood pressure drop. So if you're seeing their systolic blood pressure drop, you are now not compensating. A low blood pressure is the first and biggest sign of uncompensated shock, right? Your body has enacted all of the sympathetic um, uh, uh, drives that we've just talked about. All the gears are in full maxed out go mode, and your body cannot maintain that pressure head. And the blood pressure drops. Organs are starting to not get adequate oxygen. They're starting to undergo ischemic changes, or even worse, infarct. You're starting to have tissue damage and tissue death. Your body is starting to leak out all this bad shit that's going to go back to the heart and cause other problems, and organs are going to shut down and not do their normal function. This is not good. And so you'll see a drop in blood pressure. As that systolic blood pressure comes down and the pulse pressure comes up, that narrowing gets even worse. But once I start seeing the systolic blood pressure coming down, I don't even care about the pulse pressure anymore because the wheels have come off and we've lost the ability to maintain. So what happens is you'll have someone, when you want to talk about trends, right? You'll have someone in class 2, their systolic blood pressure is up here in the 120s. And then what'll happen is their pulse pressure will narrow. They'll go from 120s to 120 over 70, 120 over 80, 120 over 90, and then maybe 120 to 110, right? And then they'll stay there. And then all of a sudden, what happens is it's not like, oh, they go from 120 to 110 to 90 to 80. There'll be a 120, and they're compensating. And then all of a sudden, when this drops, and the whole wheels just come off, right? And so that's because our guy's ability to compensate is so great, right? So like I talked about, I prefaced at the beginning, these classes of shock. It's not we go to class 1 and then we go to class 2 and then they compensate and then they lose their ability to compensate and you start to see things fall off a little bit. It's like when you're driving a car, right? If you have some bad joints and attachments in from your axle to your wheel, right? And one of those bolts is really loose, but it's holding on for dear life. It's compensating, right? It's not like when you're driving down the highway and that bolt comes off and that U-joint, it's not like you slow down and your car wobbles and then, it wobbles some more and then you slow down some more and then you just on the side of the road. No, it's like you lose the ability to compensate. You may have a little bit of a stutter and then that wheel comes flying off, right? And it's like, that is what happens with our guys, right? It's not like they're compensating and then they lose the ability to compensate and their blood pressure slowly goes down and their mental status slowly gets worse and, and their cap refill slowly gets worse and their breathing gets faster. No. That's how it happens in the textbooks. That's how it happens in lab animals, which what we use to get this chart, right? And that's what can happen in non-healthy or not in older people too, or in people that don't have the sympathetic tone that these professional athletes have. But in our guys, right? And young, healthy military people, or just young, healthy men and women, right? What happens is they're compensating so much that they're like, they get to the end of class 2 shock and they're like, 1.5 liters, that's nothing. We can compensate that all day. Bring on 1,600 mLs. Bring on 1,700 mLs blood loss. Bring on 2 liters of blood loss, right? We're the man. Like, I'm the sympathetic nervous system here talking, right? Like, I'm the man. I can make one red blood cell bounce around at light speed and perfuse every cell in the human body if I push it fast enough, right? Like that's what your body's trying to do. Your body's trying to take 5 drops of blood and squeeze them so hard and so fast and so effectively that you don't have that drop in blood pressure, right? And that's what our guys do is their sympathetic nervous system looks at this chart and is like, it sees it as a challenge, right? It sees class 3 as a challenge, like, F that, dude. Like 1,600 liters blood loss. Like I'm not uncompensating. I'll go all day, right? And so it compensates. And you get to 1,700, it compensates. You get to 1.9 liters, 2 liters of blood loss, and their tone is so crazy strong in their vasculature. Their heart is beating so hard and so fast, and they're breathing so well and so deep that when they have finally lost the ability to compensate, there is no room left. There is no cushion of extra blood where that slide happens gradually. And what happens is you go right from class 2 shock based on your vital signs, based on the assessment we just did. You're assessing these patients and they're in class 2 shock based on what we just talked about, and they're compensating. But then all of a sudden you turn around, you go take care of someone else, and you turn back around and that guy's unconscious and dead, right? Because when the ability to compensate stopped, there was no more blood volume left, right? And now they're obtunded. Their heart rate's in the 160s. Their blood pressure's not measurable, maybe in the carotid, right? And they're doing this rapid, shallow, guppy breathing, and their hands are white and cold, and their body is white and cold, right? And you've heard of the Ranger Campbell story. This is a very common story that everyone in soft medicine's heard of before. Is the Ranger Campbell was coming off the X with a bunch of casualties. I believe he helped carry someone onto the back of the 47. And the team that was taking care of him took care of the patient he brought on, some other patients. And on their initial assessment of this guy, I mean, he clearly looked fine, right? He just carried or helped carry someone back onto the bird. He didn't have any appearance of being significantly injured, and was able to bring himself and someone else on the bird and was talking normally and was acting normally. They go and they take care of the patients that were brought in. They turn back around and Ranger Campbell is slumped over, like not talking. They get him on the table. They operate on him, and he ends up having a chest full of blood and a pulmonary vein injury. Thankfully, the team taking care of him saved his life, recognized that what we're talking about is a real thing, and didn't assess it to, oh, he's just tired, or oh, he got drugs, or oh, he had a TBI. They said, oh, that's concerning, and probably suffered some injury that we missed, or I'm not sure how that exactly unfolded, but got him on the table and took care of him and saved his life, right? Like these guys, one of my first patients, he ultimately ended up succumbing to an aortic injury in his abdomen, right, from a PKM round. But when he was brought into the trauma bay, he was talking and acting normal. He couldn't walk himself in because he was paralyzed from where the bullet had hit his spinal cord and then also injured his aorta. But this guy had an aortic injury and that was bleeding into his abdomen, and came into the trauma bay and was talking to us normally, right? And that's crazy. You'll hear this term like the walking dead, right? Or like dead man walking. This is that. This is a guy who has lost a lethal amount of blood, and their ability to compensate is so great that by the end they will look fine to you, fine, class 2 shock, and then it's not until they lose the ability to compensate, they just blast right through class 3 into I'm unconscious and dead, right? And so class 3 shock, historically, let's talk about that, is 30 to 40%. Their heart rate, we talked about, is very high. Blood pressure is starting to drop. They are orthostatic. Their cap refill is going to be delayed. They're going to have cold, white hands. They're going to be breathing very fast, and their urine output is 15 cc's or less. It's half of what it should be, right? This is all great stuff. And this is what you'll see maybe in a very slow bleed in a non-healthy patient in an ICU back home or during surgery or post-op, right? But a young, healthy kid who came in with a bad traumatic injury, who's lost a lot of blood, you're not going to see this. You're not, because their ability to compensate is so great that when, like I said, I know I sound like a broken record, but like when the wheels fall off, there is no more blood to give, right? And so class 4 shock is a very high, I would say, ineffective heart rate, almost a fibrillation heart rate, right? Like their heart rates get so fast that we're talking about the 150s, 160s. That's not a sustainable rate. I mean, people do that intermittently during periods of high physical stress, but like 160 is not a sustainable rate. And so they'll be in the 160s or higher, and it's so fast that it might as well be an arrhythmia, right? Their blood pressure is very low. It's, again, we're talking like maybe palpable carotid, maybe not, like not enough to get blood flow to their brain, because in this scenario, they're also lethargic and or obtunded. There's not enough blood flow to go to their brain, and they're passed out or passing out, right? So that's kind of my assessment of the classes of hemorrhage. Now, I know you had some questions like when to give blood, when not to give blood to these patients, right? And so you want to flush that out a little more so that I can help better answer? Yeah.
So, let's say he's in class 2 shock, right? His heart rate's, 120, 130, something like that, high, right? Obviously very stressed. There's blood on the ground. We've done hemorrhage control of the stuff we can see outside. He's breathing very rapidly. We're just doing our March things.
Mm-hmm.
But since I follow T-TRIC guidelines, TMEPS, Ranger Handbook, etc., to the letter, his systolic is not below 100, so I do not give him blood. We get access, I give him TXA, all the things. We continue moving on, and like we just walked through, they go from that class 2 shock to almost dead.
Yep.
And it can be incredibly rapidly. So I've also seen it go the other way where, we have good oxygenation, we have a good blood pressure, perfusing blood pressure, we have good distal pulses, etc. And it's like, hey, there was a GSW, there was blood on the ground, there's blood on the patient, like send more blood. So there's got to be some kind of like logical middle ground of like, this is a good time to intervene and actually prevent this person from decompensating so rapidly.
Mm-hmm. Yeah. So there's a couple, I'll say that there's two, I guess, tenets, I'll say, that that guide me in this decision making. First of all, I'll say that there's no right answer. However, there are some things that I think that if you adhere to, you'll be right most of the time. And so I'll just say, one is that, is the bleeding stopped, right? Because if someone is in class 2 hemorrhage, but the bleeding is stopped, then you are now afforded the ability to watch that patient, right? They don't need blood, right? I mean, if you have extra to give them, then you can give it to them. However, it's not necessary. right? I'm talking about the guy who came in and has a blast injury. That's maybe, or an amputation, a single amputation, right? Single amputation. The medic who was with him was on the spot and put the tourniquet on immediately, right? Lost a good amount of blood, lost about a liter of blood prior to that, but the tourniquet's on, right? They get to you, or they get to me in my trauma bay, right? And I assess them. And this is the second tenet, or this is still the first tenet, is like, are they still bleeding? So I need to now show, okay, they're not bleeding from that amputation anymore, but I need to make sure they're not bleeding anywhere else, right? Are they bleeding in the abdomen? Are they bleeding in the thigh? Are they bleeding in the chest, right? Are they bleeding in the retroperitoneum? Those are the 5 places that people can bleed: the environment, the abdomen, the retroperitoneum or pelvis, the thighs, and the chest, right? And so when someone comes into my trauma bay, ATLS, a big part of ATLS is immediately hitting where they're bleeding, how much, and are they still bleeding, right? And the where is huge, right? So someone comes in, it was a gunshot wound to the leg, it's an extremity injury, right? And they've got good hemorrhage control with a tourniquet or packing or whatever, and they are not bleeding anymore, and they are in class 2 shock, right? That is someone who doesn't, in my opinion, need blood, right? Because they're not going to, they're compensating. They're compensating, and there's not going to be a continued blood loss, right? Now, when I take that guy to the OR, right, and I'm planning on losing more blood to fix that vascular injury or what other injury they have, right, then yeah, they're going to need blood for that. But that's no longer POI. That's surgery residency stuff, right? And so, but yeah, a guy, let's say we're in Lisco, right? And there's a dude who had a gunshot wound to the leg, and it was controlled with packing. He has distal pulses intact. Um, you know, that's the guy that I would leave that packed. I would be doing pulse checks on him, making sure that any hematomas aren't getting any bigger. I would assess other places: his pelvis, his abdomen, his retroperitoneum, his chest, make sure there's no other missed sources or projectiles or blasts that are causing other bleeding. But that's the kind of guy I would watch and not give any more blood to if I'm in a resource-constrained environment or a place where I can't get him back to the rear, right? That's the kind of guy who sits off to the side, um, and you watch, right? I don't think he needs blood because in theory, he's not losing any more blood, so he's going to stay in class 2 shock, right? Um, there are some people though that you worry about in that specific scenario with no more continued blood losses. Can they continue to maintain that sympathetic tone, right? And so that's probably why I would watch them, is because not because I'm worried one, there's going to be potentially more blood loss, but also two, like when their sympathetic tone wears off, are they still going to be able to maintain? And these are kind of the guys that I think that we will see the more traditional class 3, class 4, right? Because even though they are young, healthy operators, if there's no continued source of bleeding and they're not powering through all this crazy blood loss, and then when the sympathetic wheels fall off, they're in class 4 or worse shock, right? These are the kind of guys that, like, they come in, they're in class 2, their blood pressure's fine, they're a little tachycardic, they're breathing a little fast, right? Their pulse pressure, they're in the 120 to 90 or 120 to 100 range, right? And then you let them chill out, you don't give them any more blood, you watch them, and then they will, as the sympathetic wheels come off, they will go into what appears to be class 3, right? But it's not really, because they're not continuing to bleed. What it is it's just their sympathetic drive coming down, and you need to watch them to make sure that that class 3 is not true class 3, right? Like, this would be a guy, maybe you put a Foley catheter in, see what his urine output is, measure a lactate if you have an I-stat, right? This is the kind of guy who very quickly becomes like almost an ICU patient, right? And you just watch, right? Is that when the sympathetic tone comes off, it's okay if their blood pressure comes down to like 110, 190 and then stays there, or 110, 90 and stays there, right? But as long as you've shown there's no more source of bleeding, then that's okay. That's someone I'm willing to watch, right? If I'm in a resource constrained environment. If the wheels, if the sympathetic tone comes off and they're like, oh, now I'm in like the 80s, and then the dude's like, a little more lethargic, but he's still not bleeding. That tells me that he came in, he compensated to 2, but when the dust settled, he was really a 3. Okay, that's probably someone I need to give a little bit of blood back to, right? And watch him, right? Because you don't want to keep him at class 3 for too long, right? And then they start to get all that stuff we talked about, like ischemic changes and just all of the bad humors, I'll say, of what happens when tissue starts to get injured, right? For too long, right? And so that's how I would handle that. Now, the second tenet of like whether or not to give class 2 or class 2 patients blood is their progression, right? So like I have a guy who has an injury, let's say it's an extremity injury. And again, it kind of goes hand in hand with, are they having continued source of bleeding, right? So let's say I have a guy who has an extremity injury and he's got a little bit of a hematoma there and he's in class 2 shock. But he looks good. He's talking, he's doing his gallows humor stuff. His heart rate's in the 110s, 120s. His blood pressure's also in the 110s, 120s. His shock index is not great, but his blood pressure is systolic is above 100, right? And you've ruled out the only source of bleeding could be this thigh, right? It's small hematoma, right? You've packed it. He's got blood flow distal to it, and it's a small hematoma. While I'm checking on him, I'm a little concerned that I don't have true hemorrhagic control, maybe because if the hematoma starts to get a little bit bigger, right? I'm a little worried, right? It's a little bit bigger. And let's say I don't have a surgeon, right? We're talking because if the hematoma is getting bigger, I'm taking him to surgery, right? And it's an easy answer. But let's say LISCO, right? You're LISCO, you're on the front line, you have a bunch of casualties and only so much blood, right? This guy comes in, he's got a hematoma around a bullet wound in his leg, right? We've seen it a million times. He doesn't need a tourniquet. He's got packing. He's got distal blood flow. Comes in, he's in zone 2. He's joking, he's smoking, he's talking, he's hobbling, not walking, but he's okay, right? You put him on the side, you come back, you check on him a little bit later. Now the hematoma is a little bit bigger. And you're like, well, it's not like massive. He still has pulses distal to it. His heart rate, it hasn't changed. His blood pressure's still fine. His pulse pressure maybe narrowed a little more. He's not orthostatic. His cap refill's fine, and he's breathing the same, right? Okay, I don't really feel good about that, right? Okay, you come back around a little bit again. It's a little bit bigger, but again, all of his class 2 shot, all of his class 2 vital signs are the same. But now his pulse pressure is narrowed even more. He's gotten slightly more tachycardic. And he's not the same, gallows humor kind of joking guy, right? Okay, now I'm worried, right? I have evidence that I don't have HemCon. I have evidence that, yes, he is still in class 2, and yes, JTS tells me I shouldn't give blood because his blood pressure is still over 100, but I'm worried. I'm worried because this guy is just trending in the direction I don't like, right? Because if you come back again, now the hematoma is really big and the dude's unconscious, right? Or he had some injury that you didn't know also in his pelvis too. He had a small, and he was tracking up into his pelvis, right? So it's like, it's a combination of continuous reassessment and making sure you have hemorrhage control. If you have hemorrhage control and there's no more continued source of bleeding and the patient is not trending in any direction, they don't need blood, in my opinion. Unless like we talked about, where they class 3 shows itself later. But again, that would be trending, right? You would trend that patient. You'd see, oh, okay, well, the sympathetic tone's worn off and he really is in class 3 because I've been reassessing him like I'm supposed to do. I'm not worried that he's continuing to bleeding, but he could use a little blood back, right? Whereas the second guy is kind of the guy where, like, I don't feel great about my HemCon, or I'm worried there's something else I'm missing. Because let's say he doesn't have a broken pelvis, right? Fast scans aren't good at showing blood in the retroperitoneum. He's got a big swollen thigh because it's shot. But I mean, dude, we've all been there. Like, these guys' thighs are the size of torsos, right? And it's like they can hide a lot of blood, and a hematoma in a thigh. Like, I mean, how many times have you stood there staring at a hematoma and been like, is it bigger? I don't know, like, right? You're just like, I've done it quite a bit. Where it's too late. I'm like, shoot, I don't want to fucking take this guy to the operating room. And I'm staring at it. And I'm like, and you're just like, come on, man. And then you just don't pull the trigger, right?
Right.
So
Yeah. You're regretting that you didn't put a marker on the line like you were trained to do.
yeah, exactly, right? Or you do, and you're like, well, is it past the line? But I mean, how many times have we played that game, right? And so that's the kind of guy that's the guy that I'm worried, right? Is like, I don't feel good about my HemCon. And his vital signs, yeah, he's in class 2. And then you do this whole, like, convince yourself you're in the right because some guideline told you somewhere that you're in the right. Oh, well, JTS said I don't have to get blood if it's over 100, so I'm fine. I'm doing the right thing. It's like, don't be that fucking guy. Please don't hold your hat and your patient's life on an algorithm or a guideline, right? Because they are guidelines. They are not the rules of law, right? And so no one will tell you better what to do with a patient than you being there in the situation, right? But you got to know what to look for. And if I'm looking at a guy and I don't feel good about his hemorrhage control, or I'm not in a place to operate, right? Or I'm not a surgeon, or someone that can intervene on that hemorrhage control more than I've already done, right? And I'm looking at their vital signs, and they're still technically in class 2 shock, but things are changing. Their sympathetic tone is getting ramped up. Their pulse pressure is narrowing. Their mental status is changing. Their heart rate is getting worse. They're breathing harder. These are all things that should tell you, like, you shouldn't be waiting for the blood pressure to drop in those patients for you to say, okay, now I've hit my trigger, because your trigger will be too late, right? And so, yeah, you really you you can't hang your hat on one thing, and that's with this second tenet. The first tenet is being, do I have hemorrhage control, and the second tenet being trending, right? To make a decision, I never make a decision based off of one data point. You should never, in medicine in general, you should never make a decision based off of one data point, because that's how you get in trouble. That's how you do things because the guideline told me to, or because the read on the CT scan said this, right? And that's when you find yourself in the operating room or doing a procedure, and you're like, why am I here? And then someone from the outside comes in and is like, why'd you do that? The guy's vital signs were fine. Their white count was fine. Like, they were talking to you. They kind of bring you back in reality. They're like, you took this guy to surgery based off of a read off a CT, but everything else is fine. And it's like, sometimes that's the right thing to do, but most of the time it's not the right thing to do, right? Or like, you gave this guy, blood because because their pulse pressure narrowed. Like, I don't understand. What are you doing, right? Like, or you didn't give this guy blood because their systolic blood pressure was over 100. But like, dude, did you see what else was happening, right? And so that's how you get yourself into trouble. Now, of course, there are things that there are one-offs that you act on all the time, right? Like arterial hemorrhage coming out of a leg, right? I don't need any other data points. Then that's getting a tourniquet, right? And that's going to go to OR afterwards, right? Like there are certain things that yes, you don't need more, but like than one data point. But those are actually pretty rare. And so and I would say they're rare and they're also obvious, right? Like the dude who's obtunded, who has a blood pressure of 80, gets blood. We're not here to talk about that because everyone knows what to do in that situation, right? They're obvious. We're talking about the stuff that happens before you get to the obvious, right? And so that would be one, do you have hemorrhage control? Two, what is the patient telling you? What are the trends showing you? Look at these patients and assess, get a feel for their sympathetic drive. And is it ramping up, right? And then on that, don't act off of one data point, right? Don't hold your hat on just the pulse pressure or just the mental status or just the heart rate or just the respiratory rate. Take it all into account. And if you've got 2 data points heading in the wrong direction, then I treat, right? Like I need at least 2 really good things telling me I'm heading in the same, because now it's not a coincidence, right? You can have anything can be a coincidence, but if you've got 2 data points heading in the right direction and the situation makes sense, then a zebra is a zebra, right? And so, or what is it? I think I messed that up, but a duck's a duck. There we go. I took 2 totally different ones. Hoofbeats are a horse, and a duck that quacks and it looks like a duck is a duck. So 2 data points. The situation makes sense. Call it a duck, right? So old zebra. We can fuck it. I like it. It's a zebra. If it looked like a horse that's got stripes, it's a zebra.
That's true. Clear as mud now. Thank you.
Yeah.
So, we're pushing already on an hour and a half now. So this has been really awesome.
Thought this was going to be short. I'm sorry, man.
No, that's okay. No, it was perfect because I knew this is actually a lot more complicated than people think, because like this is a human body. This is a very complex system that's been developed over a very long period of time to live. And like you mentioned, like when you look at it in a silo, this is how it happens. But life doesn't happen in a silo. There's a bunch of stuff that goes into it. This is the reality. And that's why I wanted you to jump on, is because you've seen reality over and over and over again. That's why.
Yeah. Well, thank you. Yeah. I mean, I know you wanted to talk about, we'll hold off on I'll give my quick pearls on peds and pregnant women and elderly. So peds is very difficult because the vital signs are all deranged, right? I mean, I still have trouble. What is normal vital signs for very small kids, like 6 months to 1 day to 6 months, 6 months to a year, 1 year to 2 years. The vital sign, I have to always constantly be reminding myself. Plus, it's harder to assess this stuff. It's harder to physically feel a pulse, right? It's harder to assess mental status. A lot of times the parent is going to be the one that tells you the mental status of their child and whether it's normal or not. And if there's a language barrier there, it's very difficult, right? So, and then lastly, with peds is 50 cc's could be a lot of blood loss for a little baby, right? And so for people that are used to dealing with adults, we accept this idea that like X amount of blood is acceptable. And you need to really change that, because otherwise you will be allowing a large blood volume out of a kid, and it would be the equivalent of like an incomplete blood volume, right? And so a small amount of blood in these kids under 2 years old can be a significant amount of blood. Familiarize yourself with vital signs checks, because the body does still act the same for peds, but all the stuff we talked about today, you need to be familiar on how to assess effectively, right? And then rely on the parents. The parents will be the ones to tell you whether or not their kid is acting normal. And that's a huge thing in children, is I would say mental status in children, although it's much harder to detect, is way more valuable in children because there's no societal barriers on how to act, right? There's no 2-year-old trying to tough it out, right? Their mental status is a window into how they're doing. And so it rely on it, but oftentimes you got to talk to the parents to know what's normal for that kid. Pregnant women, jumping real quick into pregnant women are like athletes. They have the ability to compensate because they've produced so much more blood volume, right? Um, and so there is a lot more blood volume in pregnant women, and they can do the same thing. They can go right from class 2 shock straight into class 4. And one of the things that can happen too is like they fight to keep their baby alive while they're in this shock state, and then they divert all of the resources that they've been giving the baby back to mom so they can have this like second wave of like, I'm not doing well, but then I'm doing well. And then the baby's getting injured and starving, and then the wheels come off, right? And so there's some things that we can do specifically with pregnant women. You lay them on their left side and you get more of that first gear sympathetic response of like reserve from the IVC and the venous system. And people poo-poo that, but that's a real thing. There's some studies that have shown that turning a mom on her left side and opening up the IVC can increase your cardiac output by 30%. Like, that's crazy. So, like, with pregnant women, that's the first thing I do. Like, why would you not do that? Like, if I could turn every soldier on their left side and give them a 30% cardiac boost, like cardiac output boost, like that's huge, right? And so it's one of those things we read about, we poo-poo, but it's real. Definitely worth taking the time to just fold up some blankets or make a little bump for your pregnant patients and lean her on her left side and really let her body do what it's meant to do. But just know that pregnant women have a massive ability to compensate. And then lastly, with the elderly do not have a great ability to compensate. Their sympathetics over time are burned out. On top of that, they're probably going to be taking drugs that slow their heart rate or slow their contractility or cause vasodilation when it shouldn't be happening. So, but believe it or not, the elderly are actually one of the crowds that I would say fall traditionally into the classes of shock. They do actually more often than I expect follow the book because of whatever reason. Now, granted, people may be on different drugs and stuff, but like which mask a lot of that, but you will see more of the traditional drops. However, they don't have the ability to eat those drops, meaning that a elderly patient in class 3 shock can't be there for long. They can't take that hit. Like the dude with congestive heart failure and kidney failure and COPD, he's not going to tolerate coming back from class 3 shock. His kidneys aren't going to take the hit. His volume, you can't give him that much volume or he'll have a heart attack or you'll need to intubate him for ARDS, right? Like you get a bad, sick old dude in class 3 shock, bringing him back from that is going to be a month or 2 in the ICU, right? So you don't we can take some class 3 shock, right? We'll be okay. We'll bounce back. It's not going to be great, but we'll be all right. An elderly guy with multiple comorbidities, the resuscitation required to bring someone out of class 3 shock or class 4 shock, you'll do it, but they'll suffer the consequences and you'll have multiple downstream effects. So the point there is, again, don't wait for class 3 shock, right? Like they won't blow through it, but they might not survive coming out of it, right? Is my marker there. Get a medical history, do a full physical assessment. These are the kind of the guys that you want to know, like, oh, hey, I can't feel a pulse or whatever. And then you look at actually do a physical exam and you see all these like scars that are contiguous with like vascular surgery. And you're like, oh yeah, maybe he's got bad vasculature, right? And that's muddying my ability to assess all the class 2 stuff. Or he's got a big median sternotomy or a big X-lap, right? Like these are all things that like, or he's got a dialysis port or dialysis, like this is all stuff in these elderly patients that like you need to take into account. Get a medical list, right? Because they will be messing with your class 2 shock assessment hard, right?
Awesome. Well, I really appreciate you jumping on and helping me out with this.
No, thank you so much. Again, sorry for for all the delays in getting here, but I love doing this. It's an honor to be here, and just thank you for having me, Dennis.
Hey, awesome. Pleasure is mine. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.